our next speaker, Dr. Rakesh Gupta, an excellent cataract surgeon, and currently our Delhi Ophthalmic Society's executive member. And you must have watched his videos on YouTube. He has a lot of innovative techniques in cataract surgery as well as refractive surgery. Welcome, Dr. Rakesh.
First of all, thank you, Dr. Adhika ma'am, Dr. Namrata ma'am, and Dr. Full for this wonderful opportunity. So, I'll be talking about dual tunnel ambidextrous phaco, which is a savior in complicated cataracts. It's a new technique which I've evolved after attaining ambidexterity, and my ambidexterity is actually acquired. So, how does this technique help? Basically, I make two tunnels which can be 90 to 180 degree apart. One side put in between two tunnels, and other side put as per your right or left handedness. Ambidexterity makes it convenient, but it is not mandatory. Even if you have preferred dexterity on one side, you can do it by simply rotating your chair from one to other side. So I'll be sharing some videos. Uh, in this video, I'm showing it's a soft posterior polar cataract. I've also shown my external video. On the left video, which is showing external video, and other is the microscopic view. So after making two tunnels, I make two trenches. So there is no hydrodissection, no delineation, no nuclear rotation required. So all the risk factors in posterior polar cataracts are taken care of. And after making two quadrants, actually two trenches, which makes four quadrants, and you crack them, and then you remove two halves, left two halves from the right tunnel, and the right two halves from the left tunnel. These techniques help wonderfully because it ensures that it reduces the risk of nucleus drop. It also reduces the risk of PC rent even during epinucleus removal. So in my hands, I have done almost more than 50 cases such now, and I never had a nucleus drop till now. So because the hydrodissection is not done, so I do viscodissection after nucleus is out, so that separates this epinucleus and cortex from the capsule, and that can be aspirated. So this is hydroimplantation in the posterior polar cataract. So this video was showing it was a soft cataract, but where is the importance of this technique? So this is a very old video when I started actually. If you see, this is a very hard cataract, grade 4 or 5 cataract and posterior polar cataract. And this patient actually was refused surgery because of, when people were telling, so almost 8 or 9 years patient was waiting, and when cataract became very hard, vision was less than 60, he agreed for the surgery. So this was one of the first few cases where I did very hard cataract. Obviously with posterior polar it was difficult, and you can see the speed. Just to accommodate more videos, I have increased the speed, but you can see now here, this is you will see the fluttering of central PC, which is very typical of posterior polars. With hard cataract also, I have been able to salvage it. Now in the third video, I will be showing where this technique helped me in helping my colleague. My colleague was doing cataract with pseudo exfoliation and phacodonosis, and you see after making waters, suddenly there was difficulty in rotating the nucleus, and every attempt to rotate the nucleus there was a zonal dialysis, which was increasing. So at this stage I took over. So I made the left tunnel, you can see now, so that helped me in depulking the capsular bag. And because there was a significant zonal dialysis by this time, you can see there is more vitreous prolapse, so I decided to do limited anterior vitrectomy, and after that I anchored one Gupta ring segment to stabilize the capsular bag. So this dual tunnel technique helped me in salvaging this. Otherwise, there was a possibly a bag with capsule would have dislocated into the posterior segment. And you see after implanting Gupta ring segment through Hoffman pocket, the capsule bag has nicely stabilized, and now I am it is like a routine case now after implanting this. So that even for one fragment when I made left tunnel, it has helped. And you can see this is a 3 weeks post-op picture of the same patient. And now now even in small people, like this is example, this patient has a complicated cataract where I did synechiae. People was not dilating, so this case suddenly came on table. I had no Malugan ring available or any ring available, so I decided to continue. So I made a Rexis, which is actually blind, but Rexis went very well because it was a soft cataract, so it was not rotating. So when I did nucleus removal, I decided to make another tunnel on the left side, and I removed right half of the cataract from the left tunnel. And now, so you can see this chopper which I am using. I have designed this chopper myself, and it is a kind of chopper cum shield which is available with Indo-German now. So this chopper also helps in avoiding iris chafing, and it guards posterior capsule, iris as well as endothelium also, depending on which area you want to focus. So again, this is a post-op one-day picture of the same patient. And now this is an interesting case where this patient had a posterior polar cataract. He wanted trifocal lens only because his brother had it. Some surgeons refused, obviously for the obvious reasons, because posterior polar cataract you can't promise trifocal lenses in all the, in both the eyes. This patient somehow came to know about this technique, and I did this. So I advise femtocataract to make central rexes. So that my plan was, if there is a rent, I will be doing pupillary captures to stabilize the synergy trifocal IOL. So you will see that after I cracked, there is a PC rent. Now you can see the gaping between these two halves is indicative of PC rent, and all quadrants are in its place. But because I have not done hydrodissection delineation, so I was confident and I continued. I could remove all 4 quadrants using both the tunnels, right and left tunnels. And you will see now at one point, this one piece is going back, and the moment I press this left tunnel, this comes some kind of Venturi effect which pulled the nucleus in this piece up, and I was able to eat this piece away. And now through the left hand, I removed other half of the, other 2 quadrants. Yes, there was a PC rent, and actually it was a large PC rent, and it was significantly hard cataract, but because of this dual tunnel, I was able to fulfill my commitment. And you will see I will be implanting a synergy lens, and with pupillary capture, there was excellent centration. So this is synergy IOL, and I pupillary captured it. So because it is femtorexis, so centration, you can see on table centration is excellent. Now this is 3 weeks post-op image. You can see the rent also, and lens is very well centered. The patient is happy. Other eye also did, and patient had a similar result. So what are the advantages? It provides opportunity to handle nucleus and epinucleus from 2 different angles and position. Less stress on zonules and PC, so there is no need for nuclear rotation. It provides alternate access to cataract fragments in case of intra-op complications, like if there is zonular dialysis, if there is a PC rent, or even sometimes there is a localized DMD in the primary tunnel. So you can make other tunnel, and you can go ahead and complete the surgery without extending the DMD or rent. It also helps keeping low pressure in the AC. I have shown in one video. When you press the second tunnel, suddenly there is 0 pressure in the anterior chamber, and if any piece is falling back, with Venturi effect, this piece may come up. It also allows maneuverability in small zones like small pupil, small capsulotomy, or sometimes if there is a peripheral opacity because of PUK. In such cases, this technique is very helpful. So in indications are posterior polar cataract with hard nucleus, phacodonosis, nuclear rotation is because it's not safe, small pupil. Without retractors also it can be done, and if there is extension or break in the rexes, and you might need another port, so that you are not manipulating in the area of extension. If there is zonular dialysis, I have shown in one of the video, and even if floppy iris, because sometimes if your primary tunnel is showing recurring iris prolapse, you can make another tunnel more anterior into the cornea, and you can continue and complete the surgery. So this is the chopper which I have designed. This has a special features, like it has a round tip, it is 2 mm long. It has a notch to hold the equator of the nucleus, so even through the small pupil, it can slide back. As you can see, there is obtuse angle. So what happens if you slide this, rubbing the cornea, even if you are not able to see iris or anterior capsule, this chopper goes up to the equator and you can chop it. So this helps in chopping in the small pupil or small capsulotomy also. It looks blind, but with experience, I have learned to manage even in difficult most cases. It has a notch to hold equator, and the cutting edge is on the inner side, so it helps in chopping even in hard cataracts. And this 2 mm long tip, it helps. For example, if there is a surge in the during surgery, so this ball will protect the capsule, the shaft will protect the iris and capsule, and rod will be protecting the endothelium. So when technologies are mastered, disasters happen faster. So I believe we should keep upgrading our skills. We should keep innovating new skills. Yes, technology is there to help, but this is one example. Technology has led Sunita Williams in space, but because of our skills to survive and unplanned 8 or 9 months stay in the space. So I think skills are very important to be developed along with the advancing technology.
Thank you, Dr. Rakesh.
Thank you.